Welcome everybody to the Australian Medico-Legal College's third webinar on Telehealth for IMEs. As with the previous two webinars, today we again have quite a large number of registrants, well over 200, indicating significant interest in this topic. The first webinar was a general conversation regarding telehealth IMEs, but our second webinar panelists provided government, insurer and lawyer perspectives and indicated that many decisions regarding telehealth IMEs are still under review. However, a clear message from the regulators and referrers in that second webinar was that it's ultimately up to the medico-legal expert to determine what we can and can't perform adequately. The advice was that we should only do whatever we can. So it's up to us. Until 3 months ago, we were living in a perfect world and our gold standard was to undertake a perfect IME assessment. However, we're now living in an imperfect world and our new gold standard is to be able to perform an adequate IME assessment. It's the definition of adequate rather than perfect that we'll be just addressing tonight. It's important for us to remember that the goal of a treating doctor is to diagnose and treat a patient, and we need to be as close as 100% accurate as we can be. But that in contrast, the goal of an IME doctor is most commonly about that filthy word money, not our money of course, but money that a second party should pay to a third party, and that we are only a cog in that wheel, a service provider, providing information on which others can make decisions. We generally only have one opportunity of examining the person and are expected to provide an opinion on balance of probabilities. Apologies. Rather than 100% certainty, balance of probabilities rather than 100% certainty. So the definition of adequate is therefore quite different to the definition of perfection that's necessary when we're the treating doctor. In this imperfect world that we've been thrown into, if we've done the best that we can and it's adequate for the needs of the referrer, then it's probably adequate even if it's not as certain to be as correct as it would be in the perfect world from before 3 months ago. Most IME assessments can be done to some degree, and the degree that we can do it is what we're discussing tonight. Nevertheless, some components of telehealth IMEs can't be performed adequately. Tonight's goal is to come to a consensus of what we can and can't do, and to then, after that, write a position paper based on the results of 17 polls, which we'll be conducting tonight with your help. Our panelists represent varying perspectives on what components of an IME assessment can be undertaken by telehealth. They represent the opinions of many IME consultants who've been writing to us over the last few months regarding telehealth IMEs. Some assessors are adamant that they shouldn't be undertaking face-to-face IMEs until they've been vaccinated against coronavirus, which of course might be another 6 to 18 months from now. And they're keen to undertake whatever components of a telehealth IME they can reasonably perform. One of our panelists, Professor Graham Mercer, will describe a second option that he undertakes, and that I know other people do as well, which is that the claimant attends a clinic where there's an allied health professional to assist in the physical examination while Professor Mercer observes via video conferencing. Other doctors believe that IME assessments by telehealth should not be performed except under very few certain circumstances. For example, a few days ago, I had a phone conversation with Professor Mohammed Ranavaya, who's president of ABIMI, and one of the editors of the AMA impairment guides that we all use in one form or another. And he was talking about his forthcoming 2-day ABIMI training sessions on the use of the AMA guides, which will be on the 13th and 14th of June. But he was also offering to be a participant in tonight's webinar, but unfortunately due to time constraints and the fact that he's, amongst other things, a professor of respiratory medicine in the US, looking after millions of COVID patients in a coma, he just didn't have the time. But he asked me to, he gave me permission to quote him. So we discussed today's webinar and he asked me to quote the following. While a good history can be obtained during tele-IME, a physical examination can't be done in a claimant's house remotely. This is his opinion. It would require an allied health professional to perform a surrogate physical examination for the IME consultant. Range of motion is very effort dependent, in other words, dependent upon the person's preparedness, and would be hard to reconcile unless a trained observer is present in the room to validate that effort. Moreover, range of motion is only one component of an overall physical exam, which includes manual muscle testing, deep tendon reflexes, tenderness and spasm, etc. However, Professor Rodavaya stated that these are unprecedented times and do require innovative solutions, and that many IME issues can be answered based just on records and perhaps on taking the history without the physical examination. So those issues that are usually asked of us, such as causation and work-relatedness, treatment and return to work. So these are the issues that will be discussed tonight. From our last two webinars, many participants have sent tips for the physical examination component by Telehealth. These have included taking a photograph or taking photographs for the range of motion and using a goniometer on that photo later after you finish the assessment, or using the goniometer pressed up against the computer screen while observing the person directly in front of the camera, sending a consent form to the claimant well in advance, obtaining a signed agreement for telehealth issues, including the items that could be in that consent form that are not usually necessary when the person presents in our clinic room, could include things like that you can have only one support person in the room. The support person must at all times remain in the view of the camera and must not prompt the claimant. The assessment must not be recorded. To get a signed permission, if you like, to take photographs of the range of motion, and get this signed permission, of course, days before you do the assessment, or get signed permission to obtain X-ray reports if you haven't got them. That the examination should be in a room large enough for the claimant to move around with a bed or sofa in view of the camera. Actually, many of those things are rather difficult for us to arrange, so the referrer should usually arrange those. And Sue Larson has advised me that she's aware of an organisation that can in fact arrange this on behalf of us or on behalf of the referrers. And Sue's got the details of that. However, the purpose of an objectively performed IME is to confirm or refute the claimed injuries. And some of the non-validation signs, like the Waddell signs that we used to refer to, but some of the non-validation signs that are used by us IME assessors are difficult or impossible to perform by telehealth, although doctors are finding creative, innovative ways to address some of these issues. And this will be comprehensively discussed by our panelists tonight. Our panelists will be discussing 4 groups of common musculoskeletal injuries: spine, upper limbs, lower limbs, and the central nervous system. For each region, the panelists will be debating what components of an IME can and can't be adequately undertaken regarding causation, diagnosis, consistency in abnormal illness behaviour, treatment, impairment, work capacity, and domestic assistance, as you can see on your screen now. After each of the body regions are discussed, after each single body region, for example, as soon as we finish the spine region, you, the audience, will be asked to vote on which components of the IME you feel you can and can't be adequately addressed with IME by Telehealth. The key word here is adequately, not perfectly, adequately, enough for the clients, the referrers to be satisfied. There'll be a total of 17 questions that you'll be asked to answer, and Sue Larson will give you further details. Now, I'd like to introduce our panelists. Professor Michael Burnside, neurosurgeon and senior approved medical specialist within the New South Wales Workers' Compensation Commission. Associate Professor Graham Mercer of South Australia, who was past president of the AOA, the Australian Orthopaedic Association. Prof Michael Shatwell, New South Wales orthopaedic surgeon and a fellow of our Australian Medico-Legal College. Prof Keith Adam, a Queensland occupational physician of great repute and Chief Medical Officer of Sonic Health Plus. Dr Drew Dixon, New South Wales orthopaedic surgeon, who's president of our Australian Medico-Legal College and also has been president of the medico-legal section of the Australian Orthopaedic Association. Dr Dominic Yong, Victorian occupational physician and president-elect of ANZOM, Australian New Zealand Society of Occupational Medicine, and myself as co-chair of the Education Committee of the Australian Medico-Legal College. while mentioning the college, if you request any information or have an interest in joining the Australian Medico-Legal College, which is an educational college, our email address is it'll be on the screen at the end of today's webinar. That's info@amlcollege.com.au, and it'll be on the screens later. So we're fortunate to have as our facilitator for tonight, Sue Larson of MEDirect. So over to you, Sue. Thank you.
Thank you, Richard. So we're going to get pretty quickly into it tonight. As Richard mentioned, we're going to be discussing 4 common musculoskeletal injuries, and with specific regard to asking our panelists tonight, to what degree, given the current COVID-19 circumstances, to what degree do they think this kind of injury can be adequately assessed via telehealth according to the 7 parameters on the screen. So we'll have 4 different kinds of body regions, and asking the same questions of our experts tonight. We will be keeping it pretty close to time as much as possible, so I'll be ringing a bell for our panelists. And as Richard said, we will, or you will all have the opportunity to vote as well. We really want to know, after you've heard the panelists and after you've had your own experience as well, what do you think? Can these body regions or musculoskeletal injuries be adequately assessed according to each of the 7 parameters? And we're going to give you the opportunity to see where your perspective fits in regards to others. There will, of course, be the opportunity to ask questions or to submit questions. The time will be pretty tight, though, tonight, and we very much want to keep to time, 1 hour 15 tonight. And so we will, as much as possible, take into account questions that come onto the screen if we're able to, and any that we're unable to do, we'll answer after the webinar tomorrow and over the preceding day. Now, you might be wondering, how do I answer a question live? This is a screenshot of what you should see at the bottom of your Zoom webinar panel. You should see firstly a Q&A icon. If you click on that, it will expand a box that looks a little bit like this on your screen right now. And that will give you the opportunity to ask questions that will be made visible to our panelists, who can then review it as they're listening to other panelists' responses, and to include those in their responses as much as possible. Now, the chat function, we'd ask you just to put chat down there if you have technical difficulties or if there are any resources that you would like to share. We've had a lot of fantastic things shared via the chat function in previous webinars. So if you would like to do that, feel free to press chat, or if you have technical difficulties, and one of our tech team in the background will contact you, and they will make sure they get you back on track as quickly as possible. Okay, so without further ado, we're going to actually start, get into the first question tonight. And the first question you'll see on your screen right now, and that is that, given the current COVID-19 circumstances, to what degree can spinal injuries, excluding CNS that we'll talk about at the end of the session tonight, to what degree can spinal injuries be adequately assessed via telehealth regarding these 5 factors: causation of symptoms, diagnosis, consistency and abnormal illness behaviour, treatment and impairment? And to start, I'm going to throw firstly to Professor Michael Burnside. Michael, we'd love to hear your thoughts on this.
Thank you, Sue. Good evening, everyone. I think it's worth starting by revisiting Richard Seckel's comments on adequacy, and you can see that adequately is underlined in the question there, and I think that's really one of the critical issues that we need to talk about tonight, and it'll be interesting to draw people into the conversation and get some views as to what adequate means. For me, adequate in the medico-legal setting really refers to the standard that the courts will accept, and this is relevant for the topics we're discussing tonight, that is injuries to the spine, musculoskeletal injuries to the limbs and the central nervous system. I think there's no doubt that, as Richard has said, this is a second-rate way of making a medico-legal assessment. And it's my view that the standards that we've all adopted over the years, and that's based on face-to-face assessment, shouldn't be sacrificed for timeliness. and throughput, and that's with regard to the pressures that the courts are putting on the system to keep the civil lists going. I've also got some concerns. I'd be interested in colleagues' opinions as to the procedural fairness of a person and the person's right to be heard in tele-IME, because I think that there are potential limitations there too. Most people will be concerned who are on the receiving end about whether their benefits can be continued and their access to treatment. And in my experience, they're in the practical terms, and permanent impairment assessment, WPI, comes further down the road. So in the general comments, I'm aware that there are jurisdictional differences across the various states, and we'll try and talk fairly generally. So if we talk to injuries to the spine, and this excludes injuries to the spinal cord, but includes injuries to the spinal nerve roots, that is radiculopathy. In terms of causation, it's certainly possible to adduce causation from the history and documentation, and I don't think those two can be separated if there can be no face-to-face examination. It's critical to have good documentation, and it's critical also to hold a telephone conference with the injured person. That doesn't replace face-to-face, because you lose the nuances, the body language, and all those sorts of things which are so important. Really, the issue in diagnosis and causation in particular is whether this is a fresh injury or it's an aggravation of a symptomatic or asymptomatic pre-existing condition. For diagnosis, much of this is clinical, particularly with regard to the presence or not of a radiculopathy, because down the road that determines a WPI rating, but it also determines an entry into future treatment and ongoing treatment. It's combined in the spine with radiology. For example, fractures of the spine can probably be determined in terms of impairment by an adequate set of x-rays, which can be sent to you, and you don't really have to see them on the screen because you calculate the loss of height of the vertebra. And it's also obvious that for treatment too, whether the person's had a spinal fusion or not, or surgery to the spine, will determine what they can or cannot achieve in WPI. When it comes to consistency in illness behaviour, it's face-to-face, in my view, because again, you need the nuances and the body language and the communication that you have with the injured person, both during the history-taking period and during the physical examination. So I don't think that can be adequately addressed by tele-IME. Past and future treatment. Past treatment is obtained from the documentation, and that's fairly straightforward. And you can deduce from that, although you must have a history, obviously, whether that was reasonably necessary, and they're the usual questions. Future treatment can probably be done on history and documentation at some times, but again, I think it's good to actually see the person, talk to them and say, well, what do you think of the treatment that's proposed? When it gets to impairment in the spine, it's a combination of a clinical and a radiological diagnosis, with the emphasis on the clinical diagnosis in particular for selecting the DRE category, because the DRE category is a clinical diagnosis. The exceptions to this, as I said, fractures, or whether the patient's had a particular operation or not. Generally, this is a spinal fusion, and in most jurisdictions now, there's a WPI rating for spinal fusion, and across the work cover, the Safe Work Australia guides, as they are now, there's waiting for more than one operation, more than one level, and all those sorts of things, which can be adduced, of course, from the documentation. So in terms of examination of the spine, if you're trying to decide between DRE category 1 and 2, in the spine, you need face-to-face examination. Whether there's a radiculopathy or not, you need face-to-face examination, because there are a lot of subtleties in diagnosis of a radiculopathy by way of segmental motor weakness, asymmetry of reflexes, sensory loss, and the like. And you can't really obtain that from a tele-IME. And Richard talked about surrogate examiners. I've thought about this a lot, and I would be very hesitant to put my name to a report where a surrogate examiner did the examination unless they were really well trained, because in the spine, the signs are often very subtle, and you really need to put your hands on the person and do the examination yourself. So in summary, a bit can be done on documents plus history. Most of it needs to be done face to face. Thank you.
Okay, thank you for that, Michael. I'd be keen to hear what others, how others feel about that. Drew Dixon, what are your thoughts around this? Because I know you've been doing a fair bit of telehealth assessments over the last 6 weeks.
Well, because of my demographic, I have not been able to do face-to-face, and because the statutory bodies in New South Wales at least have cancelled all face-to-face appointments, we are not seeing those ones. But we are being referred cases that need assessment. Some of them are spinal, and I agree with Michael that face-to-face is the gold standard. But there are certain areas where you can get a DRE category, and that is if there's been a fusion, that can give you a value. There are certain areas, if there's been a second level done, that can give you a value. There's a third area where they might have had an additional procedure done. They might have had front and back, and that can give you a number. But Michael's quite correct in that you will have difficulty assessing radiculopathy unless you can assemble over a range of evidence that there's wasting, that there's sensory change, that there's weakness, and there's a concurrent or concordant disc lesion. Now, I think spine is exceptionally difficult to give an accurate assessment, but in certain categories it's possible to give a DRE where there's been operative intervention. For example, in AMA 5, if there's been a laminectomy or discectomy or rhizolysis, it's possible to give them a DRE3. If there's been loss of motion segments such as a fusion, it's possible to go to DRE4. The grey area is going from DRE2 to DRE3 because, as Michael says, radiculopathy is hard to assess. And we are not allowed to use, in our jurisdictions, nerve conduction studies and EMGs, which sometimes is a pity because sometimes it can lead you to information about proximal causes rather than distal neuropathy and separate the two, but it's precluded by the guidelines to the guides. So I think there's parts you can do in the spine, but the big question mark is assessment of radiculopathy, sensory deficit, power. I don't think wasting is a big issue because sometimes you can see it and it can be measured by a surrogate, but I think all the other parameters are very difficult.
So in terms of radiculopathy, that seems to be a very big sticking point. Have you heard of any strategies? Have you been able to engage any strategies that have supported you to be able to get an outcome via telehealth?
I might be going out on a limb here, going out on the board, but I do try and have measurements made of the limbs, the lower limbs in particular, to see whether or not there is wasting. Often there's nothing significant. I do try and see if we can show if there's a verifiable, or shall we say, a sensory loss that is a verifiable radicular complaint, that it fits with a nerve root. This requires the cooperation of someone else who can elicit whether there is sensory change to whether it's sharp, whether it's soft sensory change, or difference with a tuning fork. Now that's difficult. All you can do with Telehealth is get something like a nail file or a sharp fingernail or and see if there's a sensory change that occurs in the radicular area. That is very, very subjective, and you're dependent on patient reporting and the person doing the test for you. I think it's still a vexed area, but I think you have to say to yourself, I'm doing this because of COVID-19. As long as both parties have agreed that it is acceptable and the claimant is happy, then I think you can proceed. Now, if neither party's happy or only one party's happy, then you can't do it. But if both parties are happy, and if the claimant agrees, then it's worth a go, but it is very, very difficult in the spine.
Yeah, and then I guess the question is where it is difficult, and I can see there are a lot of questions coming in right now about this assessing of radiculopathy as being a very difficult scenario. If you are being asked to do an assessment via telehealth and you can't make a comment on that, I guess that the comment next, and I'm going to put this to Keith, please, is how do you deal with that if there are areas that you're being asked to comment on? You know, what's the best approach to move forward? And then, Keith, we'd love to hear your view as well on, you know, which of these bits in terms of assessing spinal injuries do you think are more problematic?
I think there's a strategy that I haven't yet adopted, but I've proposed to a solicitor at the moment. In Queensland, we have the particular tyranny of distance. This is to do with a patient who's currently in Cairns. And I've proposed that I would do the assessment by telehealth using someone locally to assist to the extent they can doing the examination, but on the condition that, and I could give them a preliminary view, but on the condition that if the matter ever comes to trial or at some later stage, when there's an opportunity, when the person is in Brisbane or perhaps I can get to Cairns, that I would then conduct an examination at a later time. Again, it's not perfect, but I think in these difficult times, it's a compromise which might be worth considering.
And I think as well, you know, I think that's the point to reiterate as well, is that it is less than perfect, certainly. And when requests are still being made, it's about how do you deal with this? What is acceptable in terms of what you document, what you comment on in the report in very difficult scenarios. So thank you for that, Keith. I'd love your view, Keith, still on which of these do you think you can adequately comment on for spinal?
I think causation, would normally be fairly straightforward, and as a good occupational physician, I'd occasionally like to get out to the workplace, wherever it was, to examine what's happened and get a better understanding of the biomechanics. Diagnosis depends on the condition. There are some things that can almost be diagnosed radiologically, where there are others where the examination is critical. Consistency, again, is something where you might be relying on your examination, but you can certainly make a number of you can make a number of, get an impression about how people are presenting, and particularly whether there's consistency with what the activities they're claiming they can do and what from our experience we would expect that they should be able to do given the nature of the injury. So far as treatment's concerned, I find one of the interesting things that I'm often looking at is whether in fact people have been compliant with their treatment or whether they really have been adequately treated. And again, impairment, I think it's been covered fairly well, but it depends on the nature of the condition. I mean, a crush fracture is pretty easy, but if you look, as I said, if you're looking for neurological signs and those sorts of things, then you probably really need to do an examination. Mm-hmm. Although, as I've proposed, maybe it could be delayed.
And I think that's a resolution that has been raised in the previous webinar as well, that, you know, it could well be, well, I'm pretty sure there'll be a lot more re-examinations in the future and a lot more supplementary reports. Drew, I'm just going to quickly pop back to you just for another question that's come in, particularly regarding fusion and post-op radiculopathy, in terms of how would you assess that via telehealth examination? Have you got any strategies around that? And then I'm going to go next to Graham.
Well, it's very important because if they do have radiculopathy following surgery under AMA 5, they get an extra 3%, whereas under AMA 4th edition, there's no extra. But in AMA 4, you can actually move a category and go up to 5, category 5, and pick it up that way. That applies in the back. In the neck, it's a little bit less definite. So it is important if there's radicular complaint that you feel there's radiculopathy, you can indicate. Now, for instance, if you could say to somebody, I want you to lift your big toe, which is L5, and they can lift it beautifully on one side, the other side's limp, and you say, come on, I want you to lift it. And they work and work and work. And then you say to yourself, well, this could be an L5 weakness, you're not sure. Then you do measurements of the legs, and if there's 2 centimetres of wasting of the thigh or 1 centimetre wasting of the calf compared to the other side, that you're starting to think maybe. And then you look at the x-rays to see, has the nerve root canal been adequately decompressed by the procedure with the fusion, and you try to get an overall feel for it. It's just about impossible to elicit all the signs of radiculopathy on Telehealth unless you had a physio there doing reflexes for you and doing muscle strength testing. But if you can see visual weakness, I picked the big toe because that's something you can see. You can have a surrogate who can measure power, but all they can do is compare power on sides. They can't really gradate it. So I think it is a very good question, but if I have the feeling that there is radiculopathy following surgery, and this has been recorded by their treating surgeon and has been recorded by other IME assessors, then I think overall the balance of evidence is favouring the radiculopathy.
Okay, thank you, Drew. That's a nice segue to you, Graham, because you've had some experience with engaging physios as well to support you during these interesting times. Could you comment on the whole issue around spinal issues? Where do you think you can get some reasonably adequate answers, and where do you think are the more difficult areas?
Yes, thank you, and good evening to everyone. I've certainly been undertaking video conferencing probably about 40 or 50 times now with a experienced physiotherapist or exercise physiologist in the office. Obviously, appropriate permission needs to be undertaken for this. Look, it's just another string to your bow, basically. And I agree with many of the comments that have been made previously, and certainly with an experienced third-party examiner and talking to them beforehand about some of the subtleties that you might be looking for, a fairly good impression of, in particular, radiculopathy can be achieved. Now, I'd agree that there are some subtleties which may not be able to be documented, and in such reporting, I would actually document that I haven't been able to elicit this, or I was unable to be absolute in my assessment of that. But I think a good physiotherapist can elicit straight leg raising and evidence of calf wasting, muscle power testing. I agree, probably not to a degree, but to one side to the other. And I think a reasonable assessment can be made on those lines. As I said, there are limitations. The major limitation I see is if we have someone who is emotionally labile or has psychological issues, I think that makes the examination through a third party quite difficult. One of the reasons I talk to the physiotherapist beforehand is to stop repetitive movements, because in particular, if you've got an emotionally labile patient, that can really upset a patient from that point of view. So I think that there are aspects of it that are quite useful, but as I've said, it's just another string to your bow. The other one comment I want to make about was under diagnosis, and certainly I think amongst orthopaedic surgeons, we do have issues with radiology. I know there are people who have access to every radiology company in Australia, but I haven't got the time to do that. Reports can be satisfactory, but there are often times where we actually need to see the films. And I think if particular films are not available, then that can certainly interfere with making an accurate diagnosis. So part of the referral process is that we actually put it back on the referrer to gain us some access to the appropriate radiology portal. Sometimes that works, other times it doesn't. But the subtleties are there on X-ray review and not necessarily on the report. So I think the diagnosis from that point of view, everyone's talked about history and cause and effect. I think we've mentioned consistency in the examination, which certainly a third party can elicit whether there is consistency or not in the examination. Impairment, I think I'd agree with Drew. I think it's just tying together the components of your assessment and then making that decision whether you feel there is an adequate amount of information to come to a conclusion. And certainly in the reports that I've been writing, if I'm unhappy with the amount of information and I'm not of the opinion that there's adequate information, then I would agree that I think a later face-to-face is the only other alternative when it's available.
Thank you, Graham. Michael, just a few final comments before we move on to the next section. What are your views on this? We've talked about having a physio involved, and also Graham, thank you for your comments around imaging. I know that's been brought up in every other webinar as being an issue that, you know, if there is a role for telehealth in the future, really needs to be sorted out. But Michael Shatwell, we'd love to hear your views before we move on.
Thank you, Sue. Ladies and gentlemen, the problems we have really, you're skirting around. We have a population who are adversarial, who are not all wanting to go back to work or get into a good job. They're wanting a reward for an injury, whether it's been caused by a motor car, a trip in the supermarket, trip or slip, or it's a workers' compensation case. We really need a history, and we really need to read very carefully all of the information before the patient is contacted. We've got to actually have consent for the, as you probably, people have mentioned, but it's very wide consent, and it's very difficult for people to do that and get it done in a timely fashion. The other problem I find is that people are not really there to try and help you in the examination. I usually end up looking for hard signs, and most of the signs that we see, even in a face-to-face consultation, are soft. You can find some really hard things, then you can actually make a diagnosis, and you can actually assess the amount of the disability or impairment and go on from there. The diagnosis is still absolutely important, and a lot rests on the simple step-by-step history, look, feel, move. Now, we can do history over the phone, but verification of history, we need to be able to see the eyes of the patient on a good link. We need to be able to see the facial expressions, all 100,000 of them that are documented. We need to be able to see the body language. We need to be able to get rapport. We need to get into their heads. We're not psychologists, we're not psychiatrists, but all of these patients, one of the panelists said, if they're psychiatrically disturbed or if they're a little bit anxious, you're in trouble. They're all anxious, they're batting for themselves, they don't want to be bowled out. The person who comes, who's a gem and a beaut to examine is somebody who wants to join the armed forces, and you're a third-party assessor. They want to go back to work as soon as possible, and they're trying to kid you they're good. Now, those are the very few and far between patients that we get. The vast majority are people with very soft signs, with very shaky diagnoses. Reading the file is very, very, very important. The history is paramount, but we still have to look for orthopedic things, but we do it in every part of the body. The other thing that I'd like to just suggest is that liability. I'm liable for what I do to the patient. Am I liable for what the physiotherapist or the surrogate does to the patient? Who is going to insure them? Okay, they may be insured by other parties, but supposing somebody objects to the assessment that's given, are they liable as well as I am for being not in tune with the claimant's what's the word, expectation? I have been shattered by very many requests for please explain, because when the patient's seen the report, they've said they were shocked and they were emotionally distraught. There are people out there gunning for us. Are they going to gun for us more because we're doing telehealth? Is this a great advantage to them? The agreement between the two parties, and we all do, I'm sure we all do, joint reports for the plaintiff and the defendant. I think that's something we should try and do more of, because it really keeps us honest. It really makes us look for hard signs. We're really trying to do our best. But even at the end of a simple report, I'm sometimes wondering, with the CTP, where we've got two shoulders, we've got the neck, we've got the upper limbs, the lower limbs, the spine, I'm still in a bit of a miasma of doubt. I can't fall back on things at all over the television. I really think it's dead in the water.
Okay.
Anyway, I'm hope that it will be over and dead in the water when COVID runs out. But there are lots of issues.
Yeah, so thank you for that, Michael. We've heard a lot of differing views already, and this is why we've put these 4 body regions on and these parameters on tonight, because certainly there's been a lot of discussion after every other webinar, and it's great to hear the views of the panelists. Now we're going to give all our audience the opportunity to express their views. And what I'm going to do right now is to put a poll up, and this poll is specifically pertaining to spinal injuries. I'm going to ask you, you should be able to see the poll right now. Audience, we're going to ask your view. To what degree in the current circumstances and do you think that spinal injuries can be adequately assessed via telehealth, given that we acknowledge it's not the gold standard? Which bits do you think that you can do? And we're drilling down to each of those 5 areas that our panelists have already discussed tonight. Looking at causation, you can please feel free to start voting now. You should see that on your screen right now. So regarding causation, diagnosis, consistency in abnormal illness behaviour, looking at treatment, and looking at impairment. To what degree do you think that it can be done? I'll just give you a quick minute to complete that, and then I'll show you the results on the screen. Okay, so on your screen you should be able to see now. Basically we're seeing that causation is symptoms. Most people feel that you can determine that somewhat or fairly well via telehealth. Again, diagnosis somewhat or fairly well. Consistency or abnormal illness behaviour. Panelists, I think you can't see these results, so I'll walk you through them. So a consistency, abnormal illness behaviour, 39% have voted that a little, you can determine it via telehealth, and 29% have voted somewhat, 13% fairly well. Treatment, again, it's come in again, it's somewhat and fairly well, takes up about just under 80%, and then impairment, a little, and about 20% saying not at all. All right, so thank you for that. We actually have a record of these, so if anybody would like these after the event, we're very happy to share those with you. All right, we're going to move on now, and we're going to have a look at, we're going to start to look now at work capacity and domestic assistance. And you can see on the screen a question there. And I'm going to firstly direct this to Dominic. But if the diagnosis is accepted, to what degree can work capacity and domestic assistance needs be adequately assessed via telehealth? Dominic, as an occupational physician, work capacity is what we'd really love to hear your perspective on.
Yeah, sure. And thanks, Sue. So, yes, as an occupational physician, this is probably one of the most common questions we get asked, which is work capacity. So this is our specialty. And really, when you're looking at work capacity, we look at two different things. One's the worker and one's the actual job or the workplace. But when you're looking at the worker, and we've now been told in this scenario that the diagnosis is being made, so really the other information that you're looking to obtain is an idea of their level of function. And so function, if you're looking at sort of what you're trying to get out of the assessment, so the history, examination, investigation, function, you could probably get a fair bit of information from the history. Examination, again, as we've described already, it's quite limited. And then from the investigations or other documents, you might get certainly some information on function from treating the notes. You may get further information. They might have done a functional capacity evaluation. Sometimes we even get surveillance reports. So that all builds into the picture of function. And so that gives you that picture of sort of the worker. But then when we're talking about capacity, we're also talking about the workplace. And so as an occupational physician, we go to workplaces so we understand sort of jobs. But if you don't, then of course the worker will give you, should be able to give you a history of what they do and what their requirements are. There'd be other documents out there, job descriptions or inherent requirement documents. So the examination with limited Telehealth probably doesn't have much more information about the job. So putting it all together, I think you can certainly make a pretty good fist of give an idea about capacity for work once you've got all those building blocks together. And then of course it comes down to what question they ask you about capacity, because where I come from in Victoria, you might be asked, do they have a capacity for their pre-injury duty? Do they have an incapacity for work? Do they have a current work capacity or no current work capacity? And every definition is slightly different. But in summary, yes, with those building blocks, I would have thought that you should be able to make an opinion or a reasonable, what we call adequate opinion in regard to work capacity.
Okay, thank you for that. Keith, you spend a lot of time also on work sites and looking at work capacity. We'd love to know, what are your thoughts in terms of telehealth? Can you get the information that you need?
Look, I think most of the time I can get most or nearly all the information I need. Dominic's already given a great exposition on the steps you go through. So mindful of time, I won't repeat that. But what I find is useful is often I ask someone about, first of all, what they can do at home, and then what, if they're working or what they have been doing at work, I ask them about what they do. But if they tell me they can't do it, I start asking them why. And what I find is that over the years, having examined a lot of people, having treated a lot of people, I have a pretty fair idea about what sort of injuries may give rise to certain limitations. And I'm often looking for the consistency of their explanation. If someone says, look, yes, I really have trouble driving the forklift because I've got to use my left hand to do this, or my right hand to do that, and that's consistent with my knowledge of the work, then yes, that may tend to support their case. Where I don't know whether other people have the same experience, but I sometimes find there are people who you ask them a question and they sit there looking at you for a while, and you can see their mind ticking over as they're trying to guess what answer you want. But fortunately or unfortunately for me, and perhaps unfortunately for them, having asked a lot of people a lot of questions over the time, I have a sense of those people who are fair income and the sort of problems they have. And so often what I'm doing is matching up what I'm being told by the individual with what I have come to learn over the years is the normal sort of disability that people have, and seeing whether it matches up.
Yeah, looking for that consistency.
Yeah.
What about domestic assistance needs? Does that fall into the same category?
Look, to some extent. I mean, again, what I do is I for both of these things, I have a checklist I work through, and what I'm really looking for is consistency. People will tell me, yes, they can go out and ride their motorbike, but they can't lift a bottle of milk out of the fridge. Well, hang on, there's something wrong there. So again, I think I wear them down and ask them so many questions that they get to the stage where they can't anticipate why I'm asking it. And so I guess that's part of my tech. And so I think without underrating the, without in any sense underrating the importance of the history and the examination, what I'm doing is all the information I'm being given, I'm correlating with what I would expect based upon my experience of these sort of things in the past, and also on correlating it with what the hard evidence tells me, the physical examination, the radiology, to see whether it's all consistent. But I think you can certainly do a better fist of assessing those things than some other aspects of the report.
Graham, what's your view?
Yeah, I mean, we routinely get asked work capacity and domestic capacity, and I have to confess that certainly we don't go into it in the same degree of detail, but the same basic principles apply. We're looking for consistency in their day-to-day activities, how they present their examination, and then a list of what their work activities might be. So we're looking for a consistency in it, and I think you can get a fair idea, I think, from just the history and marrying up those aspects of it. Not in the same detail as, say, an occupational physician would, but we can get a fairly general idea of whether it fits or it doesn't.
Thanks, Graham. So look, it seems that...
Can I make a
yes, Richard.
A number of orthopaedic surgeons, I think especially, and perhaps other specialists who are not occupational physicians, get quite upset sometimes when they're asked to comment on occupational capacity, work capacity, because they say it's not their area of expertise. But what is their area of expertise is body movements. The person can bend or not bend this far, and can lift above shoulder height, and can lift a certain amount of weight, and they'd have to be very specific with that. The person can lift 5 kilograms or 10 or 50, and that is within the area of expertise of any doctor doing musculoskeletal medicine. So if you can't answer the job about, yes, well, this person could go back to shoemaking, but you can at least describe the sorts of work activities they can do, and then it is up to others to be able to fit that into the question. And I think that every musculoskeletal specialist should be able to comfortably answer a question about work capacity, and for that matter, domestic assistance along the same lines. Not whether they can and can't use a vacuum cleaner, but whether they can or can't bend or lift, etc.
Okay, thanks, Richard. It seems that this question was a little easier than the first one around spine. We're going to put it to a poll right now. First one around, do you think work capacity can adequately be assessed via telehealth, or to what degree? We'll do this pretty quickly. We're going to start to move on next to looking at upper limb, asking the same question that we have previously. In the current circumstances, to what degree can upper limb injuries be assessed adequately via telehealth? Okay, we've got most of our people voting so far, so I'm going to end the poll in just a couple of seconds. Okay, let's share the results. Those results are 49% fairly well, 34% somewhat. So there does seem to be a function there for telehealth for this, for work capacity. Let's have a look now as well at domestic assistance needs. Again, just a very quick poll that I'm going to launch right now. Okay, as those votes are coming in, we're going to start to move to the question around upper limb that you should be able to see on the screen right now, and that's around in the current environment, to what degree can upper limb injuries be assessed? Quickly show you the results of this poll. So domestic assistance needs, most people feel that telehealth could be used fairly well or somewhat well to assess domestic assistance needs. Thank you for that. Okay, so now we're going to seek firstly Dominic's view on upper limb and whether you think telehealth has an application here, and if so, in what capacity?
Okay, well, I didn't realise I was the upper limb expert, but I'll tell you my views. Again, if I look at telehealth compared to face-to-face, you know, what we're trying to do initially is to, you know, diagnoses, do the history, the examination, investigations, and, you know, face-to-face versus telehealth, history and investigation seems pretty sort of similar. As we said, you don't quite get the nuanced history, but it's really that examination, which is where there's the difference. You really can't touch individual. You know, you can ask them to move, you might be able to ask them to point to areas of tenderness. There are none of those things that we're looking for, whether it be reflexes or power testing. You really can't do. So it does limit it so much. So, so if you're then looking at those criteria, those categories, you know, causation, yes, if you can get to a diagnosis and, you know, you understand a bit of how they're trying to explain how they got their injury, and you understand the nature of the work, then yes, I'm pretty confident you can make that step. Diagnosis, as we said, if you can get that with your limited examination, reasonably comfortable. I think treatment would be the same, but I have a few concerns with the consistency bit we've talked about before. And then with impairment, so I don't do a lot of impairment. I'm on the medical panels of Victoria. We do a little bit of impairment assessment, which I'm for. Some of it is range of movement. So if it's purely range of movement with a goniometer, you've got a bit of a, you can make some assessment, but sometimes you are asked about crepitus, and sometimes there are other, you know, JMR assessments or even neurological assessments, which you really, I feel you can't do. So that would be sort of my summary of upper limb from my expertise.
Thank you, Dominic. Graham, you do quite a bit of this as well. What's your view on which bits are a little more problematic than others?
Again, I think through a third party, you can obtain a good assessment of you know, shoulder, elbow, wrist. I think the problematic area to me would be something like a complex hand injury. I must say I wouldn't even attempt it, only because it's very complex, and you're asking someone to measure serial movements of digits, look at sensation in digits. So I think that's one area that I certainly personally wouldn't offer to assess, on the basis that I think it just takes time and it's got to be face to face. But as for other injuries around the shoulder, again, I think the investigations are very important, especially with shoulders. Good history is important, whether they've had previous injuries, even what the other shoulder's been doing, to see whether they've had a pre-existing rotator cuff tear tendency. And again, I think a hands-on examination by a third party can look at ranges of movement and look for inconsistencies. Also, you can, I mean, the examination of shoulders, in particular, provocation testing can be taught to the third party examiner, I think quite successfully. And as was just being mentioned, more subtle things like abnormal movement of scapula or muscle wasting can also be assessed. So I think, with the exception of probably complex hand injuries, a reasonable assessment can be made in someone who is, let's say, cooperative. Again, if you've got the patient who is emotionally labile or psychologically challenged, then you're going to get inconsistencies in your examination, and that's what you put in the report.
Okay, thank you for that, Graham. Michael Shackwell, love to hear your thoughts.
Now, thank you, Sue. The problem is very few of our patients are ideal to examine. They're usually injured and they have their baggage that they're carrying to the consultation. The average patient isn't the fit young physio that you've got demonstrating for you ranges of movement. There's somebody like a granny of 84 who's had a subcapital fracture of the neck of the femur, of the humerus in the upper limb, and trying to even undress her for examination is a lengthy process. You can look at the x-rays and you can estimate the degree of possible movement in the shoulder with some skill. And that's probably one of the easiest joints that you're going to get. When you get to the elbow with the complex motion that the patient doesn't understand, you can probably make a good guess. But the wrist, even the wrist, I found a I was alerted to, I didn't find it, a journal article in November 2019 from the Journal of Hand Surgery. And this was Kelly L. Scott et al., who did a study looking at remote assessment, which is what we're talking about. And they were looking at the wrist joint, which is a pretty simple wrist joint. It's got movement in 2 planes and rotation. Some purists will say that's forearm or elbow. It's part of the motion. They found that visual estimation is not valid, that they couldn't actually make good comparisons between face-to-face touch and feel movements made by an examiner with a goniometer and somebody on a telehealth basis doing an exam, even with photographs or stills or tracings taken of a wrist joint. As Graham says, when you come to the hand, don't even attempt it. Now, we do need to have a little bit of cooperation. We do need to assess consistency. And in most of these cases, we're not looking at an injury as such. We're looking at symptoms of a very soft minor injury. That's most of the cases. Most of the cases that come to contention are not straightforward Colles fractures. Those people seem to get better. But the guy who hasn't got a fracture, who's got a sprained wrist with nothing to see on X-ray imaging and nothing to feel on examination is a real challenge to assess. We do need to actually put our thumbs on the wrist and examine all the little joints. We do need to actually stroke the fingers to see if they're moving properly and if they've got normal sensation. We do need to try them gripping things to see if they really can. Because when you get a JMAR value of 4 kilograms or 0 kilograms, you know that that person couldn't have lifted the X-ray bag to bring it into the room. So you've got to remember we're very, very limited. So I'm sorry that I'm not enthusiastic for telehealth, because it's a neurological examination as much as a vascular examination, as much as any other part. And it's just very, very, very difficult. You can't get somebody to even measure simple body size accurately. If you measure 7 centimeters below the elbow crease, is it accurate? Has your surrogate done it? You wouldn't trust the patient to do it. So I'm sorry, I like to think that COVID will go away and we'll be able to get back to work.
So lots of different Burnside.
Could I just make a comment about peripheral nerve injuries? And this relates both to the upper and the lower limb. I think that peripheral nerve injuries, which are not uncommon, particularly in the upper limb, need to be assessed face to face. And the reason for that is that you've got to do an assessment of the innervated muscles and give that a grading for power. You've got to do an assessment of the sensory loss, pain, paresthesia, and you've got to give that a grading. And then you've got to put that together and come to a diagnosis and B, an impairment rating. Nerve conduction studies in this situation are helpful, but I think that a competent examiner should be able to make a clinical diagnosis of a significant peripheral nerve injury in the upper limb, and the nerve conduction studies are used for confirmation of your diagnosis, and then you go on to make the impairment assessment. The other comment I'd make is for brachial plexus injuries, and I think here an MRI scan in the acute stage is quite useful, because you often see some edema in one of the cords, bands, divisions or branches of the brachial plexus. And that's quite useful to confirm the diagnosis at the early stage, but the edema resolves over 3 or 4 months. So late, it's not so helpful.
Okay, thank you for your comments. We're going to take it to a poll now, just asking the audience what their view is. Do they think that an upper limb injury can be assessed by telehealth, and if so, which components Now, as we do that, I'd like to ask the panelists a question that has come in here. I don't mind who answers it, maybe pop your hand up, but how does one differentiate between shoulder and neck when considering the Guyane principle? Who'd like to take that one on?
That's pronounced Nguyen, the Vietnamese name.
Nguyen.
And it's only relevant to New South Wales.
Nguyen, yeah.
Yeah, it's only relevant to New South Wales, so nobody else from other states would have any idea what we're talking about.
Okay.
Do you want to explain it?
The thing is, to me, if they're the driver of the car and they've had a seatbelt injury, they've got a concomitant injury to their neck and right shoulder. If they can explain how the injury occurred on the other side, if they're the driver, they'll often say, I was reaching out and I put my hand against the console on impact, or I was gripping the steering wheel. If there's something that suggests an injury to the shoulder as well as the whiplash, then I will look at it closely.
And what about via Telehealth?
Telehealth, they can point out where the muscles, where the cervical facet joints are tender, and they can show you with range of motion, particularly lateral tilt and lateral rotation, where the muscles are tight, particularly the trapezius muscle.
Okay. All right. Thank you for that, Drew. We're going to finish we've only got 50% voted. So quickly, last votes before we go live on this poll. And I know there's lots of questions. You're probably all listening to Drew's response. So thank you all for that. Let's just have a little look. Also, direct questions while we're waiting for the last polls for Dr. Shatwell and Dr. Burnside to comment on the Nguyen principle, Richard. My Vietnamese is not very strong, is it? When assessing...
Nguyen.
Nguyen, that's right. Michael said it better. Nguyen.
Okay, Nguyen. Principle, is that okay? When assessing the neck and upper limb. So let's go firstly to Dr. Shatwell, then Dr. Burnside.
Hi. I saw a chap today who had a car accident that wasn't very forceful, both cars going in the same direction, but for the last year he's been suffering from neck, back, bilateral shoulder pain. And my fog of doubt was still there, whether or not we try and say the shoulder discomfort is from his neck or that he's got bilateral rotator cuff disease. The guy hasn't been able to drive his Uber taxi for a whole year. He's probably quite happy because the taxi driver that brought me here today said business has been very poor. But anyway, I find it extraordinarily difficult, even in clinical practice and so as a so-called expert, to assess whether there are not, because these are older patients, they're bound to have abnormalities on their ultrasound. I've never seen a normal ultrasound. They're bound to have abnormalities on their MRI. They're bound to have in their head the idea they've got a problem. And they will show you a limited range of movement. It's all very, very difficult. You have to use every single trick in the book to assess them. And at the end of the day, you toss it up. Ask Michael.
Okay, Michael, we're going to ask you.
The Nguyen decision went to consequential injuries of the shoulders secondary to neck injuries. It's an awful decision. It was in the Supreme Court to have to deal with, and we have to deal with it in New South Wales fairly commonly. I think the important things are to examine the contemporaneous general practitioner's notes and get the history as to whether there were any shoulder problems earlier. And often the general practitioner's notes will be more accurate than the patient's recollections. Then if there's significant pain from the neck across the shoulder girdle, particularly if there's radicular pain and it's severe and been going on for some time, I think that it's reasonable to consider that there may be a consequential injury. The next question is as to whether it's permanent, and it may not be. I had a cervical foraminotomy many years ago, and I got a ghastly capsulitis for 12 months, which then went away, so it wasn't permanent, thank goodness. So I know it isn't always, but if you see people 3 and 4 years down the track after significant cervical injury and they have loss of range of motion of the shoulder and pain, then I'd be, well, the decision of the court was that we are to consider that as a consequential injury, and it is rateable.
Great, thank you for that. Okay, so the next question is going to go to Keith to begin with. Sorry, just bear with me. I've lost my control panel right now. So Keith, we're going to ask you firstly this question, and it's the same one that we've been asking so far, but around lower limb. What are your views?
Look, it's easy to start by saying again, it depends. Again, causation, I find is often reasonably easy to determine because it depends on a whole lot of other factors around the biomechanics of the injury and the consequences. Diagnosis can be more difficult, and certainly in the group of people I see, again, they're often older. Often one of the issues, either pre-existing or as part of the injury, is degenerative change in the knees, and certainly I find it often important to be able to examine the knee, and I don't know how other people can examine crepitus for you. So I think there are some problems in terms of examination. The other technique that I often find in all my examinations, but is particularly useful in the lower limb, is I often use a degree of distraction. People can't move their knee, but when I and they are concentrating on me examining their ankle, it's surprising how much more range of movement appears in the knee sometimes. So I would find it very difficult, I think, to reach a final diagnosis in many of these cases without the opportunity to examine them. Again, consistency in abnormal illness behaviour. It's often about their presentation, the way they describe their symptoms. And again, I find that I'm often, when I start drilling down, people often seem to come along schooled with a list of symptoms. But when you actually start saying, well, yes, but how does that affect you, or why, or at what time of the day, they become less certain. And as they become less certain, so do I become less certain about their diagnosis. So look, I think it's probably like all the other areas. There are some conditions which might be fairly easy to assess. Others really are more difficult. I mean, the other thing about the impairment of the lower limb, of course, is you're really required to consider a number of different methodologies and then arrive at the one which is most favourable. So you can't, for example, just rely on range of movement. And I also find that for a lot of my examinations, although the patient doesn't quite appreciate it, my examination is, in part, is watching them as they go across to the examination couch, how they climb onto the couch. And again, I'm looking for consistency. So again, I don't know that I could really give an adequate assessment of a lower limb without the opportunity to actually have hands-on at some stage.
Okay, thank you for that, Keith. I think I won't throw to Michael Shatwell. I think he's probably saying a very similar thing, laying on of hands to really get the correct diagnosis.
Can I make one little point?
Sure.
I don't think anybody can show off somebody's hip movements by themselves. They need a little bit of assistance to carry the leg. It's virtually impossible to examine a hip in all the ranges of motion possible if you're doing it by yourself, if you're over 50 or over 60 or over 70. You know, the physios can show you that they can do the splits, but they're exceptional patients. You really need the hands-on, the look, feel, and move, and the consistency is, as Keith said, that we really need to watch the patient do things in the examination room. Most of the examination is watching the patient.
Thank you for that. Okay, in the interest of time, I'm just going to throw to you, Drew, for a very quick response. We're starting to hear a lot of similarity over the answers already, so getting a good flavour, I guess, of where we think telehealth does and doesn't fit in. Drew, your thoughts just around lower limb, and then we'll move on to look at CNS.
Just to answer Graham's question quickly, I get them to take the iPhone or iPad to their knee and get them to squat. And you can hear the crepitus loud and clear. So it's audible crepitus. Secondly, I think it's a very important thing to view the patient vertically to see whether or not there is malalignment, or is there ligamentous instability on standing? Thirdly, I think gait analysis, not just walking, it's toe walking, heel walking, going on their toes, looking at the posture of the heel and the foot. These things start to add up. Muscle measurements, range of motion can be done, but you should look at things like maltracking of the patella, look at things from behind, is there popliteal fullness, look at things from the side, can they reproduce recurvatum, and look for other signs that might conflict with the assessment of wasting, such as edema and varicose veins, etc. So you can get a feel for the patient if you view them vertically, you mobilise them, and you look from front, side, and back. Very important. And the last thing is the posture of the foot and ankle. Do they have pes planus or flat foot? Do they have a valgus heel or a varus heel? Does it correct on toe standing? These are little things that can give you an idea.
Mm-hmm. So there are some alternate examinations that are available at your disposal. We're going to take it now to the poll. What do you think in terms of lower limb injuries? What do you think you can do? What do you think you can't do? And don't forget, we do have these poll results available after, if you are at all interested in what the consensus is, or where people fall and where you fall within that. We're going to, while you're answering this poll, again, in the interest of time, we're going to move on to looking at CNS. And sorry, just bear with me one moment. We're going to be looking now at the question of CNS injuries and referring this section completely to Professor Burnside. To what degree can CNS injuries be adequately assessed by telehealth? Over to you, Michael.
Thanks, Susan. The central nervous system consists of the brain and the spinal cord, so I'll address my comments to traumatic brain injury and spinal cord injury as against injuries to the spine, i.e. the vertebral column. For traumatic brain injury, generally speaking, I think there's little option other than a face-to-face assessment, and that really runs for all grades, through minor, through severe traumatic brain injury. And the reason for that is that history is so important in terms of the nuances, the body language, support, additional information, and history from a relative or a carer is really important in informing a view as to the severity of the brain injury and the degree of recovery. Causation isn't normally so much of a problem because the person is usually amnesic for the injury, so one relies on the ambulance records and the hospital records for causation, and that's fairly straightforward. In most of the jurisdictions now, there are thresholds for assessment of impairment of brain injury. That is, there needs to be medically verified significant abnormalities of the Glasgow Coma scale and post-traumatic amnesia, or there needs to be abnormal brain imaging. The diagnoses are generally self-evident from the documentation, and there are a number of different categorisations of severe, moderate and minor, depending on GCS or post-traumatic amnesia. The diagnosis of severity, again, as I say, is bound up very much in the relationship that the examiner makes with the injured person at the time of the assessment, or that's my experience anyway. And as I say, the history provided by a support person or a relative is often very helpful, because patients tend to, genuinely injured patients tend to underestimate their abilities or understate their abilities, and so you rely on a relative to get a more consistent history. The physical examination is for certainly moderate and severe brain injury is critical, and it can't be done any way other than face-to-face, because you've really got to make a judgment about higher centre functioning, and this goes to examination. You might do a mini mental state examination, examination of coordination of the upper and lower limbs, walking and balance, cranial nerves, whether they're anosmic or not. That really just has to be done face to face, and that, in my view, is the end of it. An important component, of course, is the rehabilitation documentation from brain injury units. There are brain injury units through Australia now, and the significantly injured people will be monitored, treated, and rehabilitated through them, and their documentation is critical. And the other plank of that is neuropsychological assessment. And it's important that even down the track, when people are coming forward 5 years later, that you have an up-to-date neuropsychological assessment before you make a WPI impairment. And this will pick up those at the lower end of the head injury spectrum, where there's inconsistency between the neuropsychological testing and the patient's complaints, and that's really critical in terms of assessment of where to go and impairment. Treatment is not usually an issue, because treatment's really all over by the time they come to us, and if they've got a surgically treatable lesion, that's been dealt with within the first few hours of the injury, and the ongoing treatment is rehabilitation and adaptive treatment. Again, work capacity. I'll be interested in my occupational health colleagues' comments on this, but generally it's been determined through the brain injury unit, and they're pretty thorough in assessments of what people can do and what people can't do. And again, it depends on their intellectual ability or intellectual capacity estimated pre-morbidly, what they are now, what the difference is, and the higher centre problems and their physical incapacity. So in traumatic brain injury, you're assessing both psychological higher cerebral functions, and that includes language and communication, as well as physical incapacity. So you can get a pretty fair idea of not only work capacity, but also domestic assistance requirements from the brain injury documentation, from the person themselves, or from the people they live with, because often, particularly in a severe traumatic brain injury, they'll be dependent for ADLs on someone, at least in part, if not in whole. The other issue that the court, the solicitors often, or the insurers often will ask, is testamentary capacity, whether they can manage money or not, and then that's a judgment as to whether they can understand what's being told to them, whether they can act on a decision, make a decision, whether they can act on a decision, and whether they can be persuaded or not from that decision. And that's something that I think you can, again, only determine in a face-to-face situation. So for traumatic brain injury, at most ends of the spectrum, it's in my view got to be face-to-face, apart from causation. Permanent impairment flows from the clinical findings and from the documentation supported by the neuropsych findings. The thresholds in those jurisdictions of use, thresholds has to be satisfied, and then you construct the clinical dementia rating, and you adduce the higher cerebral functions. In some jurisdictions, it's permitted to combine them. AMA4 and AMA5 do not permit that, which in my humble view is a very bad error on the part of the authors of that chapter in those AMA guides. We do allow it in workers' comp in New South Wales, but not in motor accidents, and I think that's very, very unfair. So if we turn to spinal cord injury, that is really in two parts. If you consider the ASIA, that's the American Society of American Spinal Injury Association grading A, and then B to E. A is a complete lesion. Assessment of a complete lesion is generally pretty straightforward, because if you're quadriplegic or paraplegic, then you get a high WPI. You're very limited in ADLs. There are pretty well-defined pathways, both for treatment, for assistance, for community access, and the only question then is whether the person's capable of any work or not. For a quadriplegic, generally not. For a paraplegic, maybe, depends on what transferable skills they have. For the incomplete spinal cord injury, that's ASIA B to E. I think you've really got to do it face to face, because you've got to do a physical examination. The histories, I guess, could be adduced over the phone. The physical examination is critical, because you've got to be able to work out the functional capacity of what the people can do, whether they can use their hands, whether they can write, whether they can type, whether they can walk, what their bowel and bladder function is like. So I think that I'd be very unhappy about using surrogates. I've heard the discussion tonight. I remain very apprehensive about the use of surrogates, but I agree with Graham that a good physiotherapist, particularly one who does a lot of spinal work, can probably do a better physical examination than any of us here in terms of the spine and the nerves, because they do it all the time. They don't put it together in terms of a diagnosis and treatment, but they do in terms of physiotherapy. But in terms of physical examination, they're generally pretty good. So I think that in summary then, for complete spinal cord lesions, you can probably do it on the papers and by a telephone hookup. For incomplete spinal cord lesions, where there is some functional capacity residual, then it's in my view, it's got to be face to face.
Okay, thank you, Michael. And thank you to all of our panellists tonight, and thank you for our attendees who are still on the line and contributing chat and questions. Thank you so much for that. We're going to wrap up now. I think we've had a really good discussion about the application of telehealth, and certainly it has significant issues, but it also has potential application in some areas. So I'd like to thank you for that. I'm going to hand over now to Richard to wrap up.
Thanks, Sue. Yeah, look, we're in an imperfect world. We can't have perfect answers, and some questions can only be answered with further time and trial and error. I think tonight that we've progressed extensively in the path towards what can and can't be done by telehealth IMEs. The results of tonight's poll will be the basis of a position paper that will be created by the Australian Medico-Legal College. I think a number of those polls indicated pretty strong opinions one way or the other. Some of them were equivocal. The Australian Medico-Legal College is a not-for-profit educational college with a training syllabus for trainee fellows of the college, and we welcome your inquiries. So if anybody wishes to join or find out how to become a trainee or a member, our email is on the screen now, and you can write to info@amlcollege.com.au. So on behalf of the Australian Medico-Legal College, and in fact on behalf of all of the other medical colleges who joined us tonight, I'd like to thank the panellists immensely for their time and effort and perceptive insights. And as we all consider how best to navigate this crazy new landscape, you've also highlighted more issues that need to be resolved in the immediate future. I'd also like to thank you, Sue Larson, and MEDirect for your extraordinary time, energy, and skill in facilitating tonight's webinar. You spent a huge amount of time preparing for it tonight. We all, Australian Medico-Legal College, really thanks you for that. The webinar has been recorded and will be available on the Australian Medico-Legal College website in the next few days. Our president, Drew Dixon, has also compiled some suggestions regarding telehealth IMEs that will be available on the website in the next 1 or 2 days. And most importantly, thank you, our audience, for your attendance tonight and your extremely helpful input in these polls. Many of you have submitted questions or comments, and we'll respond to those in the next few days. And we thank you again for your interest and involvement. So thank you all, and good night.